This video is on the ventricular system. Now let's just recap some anatomy that we've been through. We talked about the cortex with all its different lobes. We talked about the spine, and then we talked about a piece of the brain that connects the two, the brainstem. And then in our last video, we talked about the cerebellum, this little goober on the back of your occipital lobe. And that is the anatomy we've discussed so far, correct? Now the ventricular system is a series of cavities that are filled with fluid. It's kind of like your heart ventricle. It has a cavity filled with fluid. And here's no different. So you have a series of cavities filled with fluid. And the reason why we have this is to keep the brain buoyant. And that fluid kind of bathes the inside and the outside of the brain, kind of cushions it. So it's very important. And if you were designing the ventricular system, make sure you cover a lot of the surface area of the brain. Yeah, you wouldn't want to make some small cavity up here and call it the ventricular system. That just doesn't cut it. And so our ventricular system is this very vast array of cavities. We have one cavity for each hemisphere. So if we look at the brain this way, we have our hemispheres, right? And then our cerebellum's right here, and then our spine, and our brainstem, and our spine. So we have one cavity or ventricle for each hemisphere. We call these your lateral ventricles. And these lateral ventricles will drain into a ventricle in the middle. Just right in the middle. Covers that area. Via the intraventricular foramen. That's a fitting name. A foramen between the ventricles. And it'll drain these ventricles into the center ventricle. And if these were the first two, the first ventricle and the second ventricle, then this would be the third ventricle. And that's what we call it the third ventricle. And this third ventricle will drain into another ventricle via the cerebral aqueduct. And if this is the third ventricle, what do you think the next ventricle is going to be called? It's going to be called the fourth. So that's the fourth. All that fluid that's been drained into the fourth ventricle has a lot of different ways it can go. It can go down the spinal cord, or it can leave and go out and kind of bask and cushion the brain. It can leave because it has these two openings on the sides. We call these lateral apentures. A fancy name for them, foramen Luschka. L, you can remember L for lateral. But the more, I guess, scientific name, lateral apentures. And then there's one in the middle called the medial or the median aperture. Fancy name for that, foramen Magendie. M for medial, M for Magendie. So it can either go down the spinal cord or it can leave the ventricle and kind of bask and cushion the brain. Now, what is this fluid that supports the brain and the spine? The cerebrum and the spine, we call it cerebral spinal fluid. So this fluid is called CSF. What support cell makes CSF? Hopefully you remember. There's not a lot of support cells out there. Recall there's only like 5. It'd be your ependymal cells. And sure enough, all these ventricles are lined with ependymal cells. And there are complexes of these ependymal cells, these specialized complexes that particularly produce a lot of CSF. We call these choroid plexus. Don't get caught up with the terminology. A choroid plexus is just a specialized group of ependymal cells. They produce CSF. Call it choroid because it has a lot of capillaries. It looks very vascular. It looks kind of like your chorion of the placenta. So we call it this choroid plexus. But it produces all the CSF and kind of helps bathe and bask your brain and your spinal cord. And it'll keep producing the CSF, and you can imagine there's a problem. We need to drain it somehow. How do we drain CSF? We've already talked about it. So hopefully some of these things are coming together. Yeah, it's not just all new information. You're not just taken aback by it. Otherwise, I'm not doing my job. So how do we drain our CSF? It'd be in your meninges, in particular in your duro-venous sinuses. Do you recall the structure of your meninges? We said the outside layer is your dura mater, and you have 2 layers of dura. And in between, you had your dura, or dural venous sinus. And that drained your veins and your blood and also your CSF. The next layer in your meninges would be your arachnoid, and in this space beneath your arachnoid, aka the subarachnoid space, was all your blood vessels and your actual CSF. And then last but not least, you had your pia mater, your last layer of your meninges. So all that CSF can go to your fourth ventricle, go in your spine, or drain out and bathe your brain, and eventually collect into your subarachnoid space. That's where all your CSF is. And how does it get to the dura venous sinus, where it eventually needs to drain? We said it gets there via these projections called granulations, subarachnoid granulations. Again, hopefully that's more of a review than learning something new. Otherwise, I didn't do my job. That is how your ventricular system works. Now, how is it made in the first place? How is this complicated cavity made in the first place? To understand that, we have to take a further step back. Let's go all the way back, actually. Let's go all the way back to the formation of your central nervous system. Do you remember our first video together in this block? Do you remember how your central nervous system was made? We said it was made with a tube called the that shouldn't use brown, that looks like a dookie. It was made with a tube, the neural tube, and we said that tube would grow, and as it grows, it'll start to bulge out, and these bulges will eventually, and the bulges in the front will eventually coalesce and form your brain, and then the bottom of the tube will form your spinal cord, and that is how we got our central nervous system. Hopefully you remember that. And initially we had, if we look at this picture, initially we had 3 bulges. And then your spinal cord at the bottom. And the bulge in the front, or the forefront, would be your forebrain, aka your prosencephalon. And then the bulge in the middle is going to be your midbrain, or your mesencephalon. And then on the hind end, the bulge here is going to be your hindbrain, or your rhombencephalon. And we said as it grew and became more complicated, these 3 bulges would eventually become 5. So your procephalon will split up and make your telencephalon. And that becomes your hemispheres, your cerebral hemispheres. So our hemispheres. And then it will also make your diencephalon, which makes your thalamus. Your midbrain is not complicated, stays your midbrain. So midbrain. Your hindbrain will join as forebrain brother and split up, become your metencephalon, and that becomes your pons. So your pons and your cerebellum, and your cerebellum and the last thing your rhombencephalon makes is your myelencephalon, and that becomes your medulla. That is how your CNS is formed. Why are we talking about this? Well, not only does this form your CNS, but it also makes your ventricular system. What do you think the telencephalon, what part of the ventricular system do you think your telencephalon makes? It makes your cerebral hemispheres. So what part of the ventricular system do you think it contributes to? This will also make your lateral ventricles. Makes perfect sense. How about here your diencephalon that makes your thalamus, this kind of structure in the middle? That would make your third ventricle. And we're just gonna work down the list, all right? Your midbrain. So the midbrain is just gonna be right below it. This is gonna be your cerebral aqueduct. So if that's your cerebral aqueduct, the last thing we have is our 4th ventricle. We have 2 more remaining structures. And so we kind of split up the 4th ventricle. Your metencephalon, pons and cerebellum, makes up your upper 4th ventricle. So right, upper, 4th. And then your myelencephalon, which makes up your medulla, will make up your lower 4th. So just kind of split up that last bit. And that is how you make your ventricular system. That is a giant mess. Saw this entirety. We're very, very hard to read writing, but the better pictures will be in my notes, okay? So as long as you get the gist of it, I think you can follow along with my notes better. That is how you make your ventricular system, and that's how your ventricular system works. Now, what can go wrong? Your ventricular system is made up of CSF, and you need to drain that CSF. Otherwise, it would build and build and build. We said it drains in your subarachnoid space, and through your granulations will go up into your dural venous sinuses. All right, now we've already talked about things that can block that drainage. We talked about subarachnoid hemorrhage, where you just blow out your subarachnoid space and you can't drain it anymore. We talked about Chiari, where you had your cerebellum herniate through that foramen magnum and smush the living crap out of your aqueduct in your fourth ventricle and basically caused the blockage and couldn't drain it. So we talked about subarachnoid hemorrhage. We talked about things like Chiari. How about Dandy Walker, where you have an enlargement of your fourth ventricle and that fluid just kind of builds up. So these are just some ways where we can block the drainage of CSF, and when we block it, we have that buildup and we call that hydrocephalus. Hydrocephalus. That is increased CSF. And that shows up as increased intracranial pressure, as you can imagine. Common symptoms, if you just have this pressure building in your head, you can imagine what the symptoms are going to be like. It's going to be like headaches. You're going to see how that, it's going to be pounding against your eyes. You're going to have papilloedema. So these are just some symptoms that make you worry about raised ICP. Now, these are just some ways we can get raised ICP. There's a numerous amount of ways, and it can be confusing because there's so many different mechanisms. So we try and categorize it into two groups. It is either communicating hydrocephalus or non-communicating. What the heck do these terms mean? Communicating means that your ventricles are communicating with each other. Yeah, they're patent, they're open, the fluid can travel. So if the fluid can travel, then how on earth is it not being drained? Well, if you blow out your subarachnoid space, like in subarachnoid hemorrhage, then it can't drain. There's no granulations to drain it. And so subarachnoid hemorrhage would be categorized as a communicating hydrocephalus. Do you understand? Non-communicating means that these ventricles do not communicate, do not talk to each other. The fluid does not flow through. That's a fancy way of saying there's some sort of obstruction. When you're obstructing the ventricles, they're not able to communicate with each other anymore. So if we have like a block right here in the cerebral aqueduct, then the top part can't communicate with the bottom part. So things like Chiari, things would be an obstruction when you're smashing your aqueduct and you're stopping that flow, and it causes obstruction, causes hydrocephalus, causes CSF to build. You can also have things like congenital aqueduct stenosis. What do you think that does? What do you think congenital aqueduct stenosis is? You're born with your aqueduct a little bit more stenosed, more narrow, and that can cause it too. In fact, it's one of the more common causes of hydrocephalus in a newborn. You'll see this baby with his giant head just full of fluid. How do we treat that? We just shunt that fluid into your abdominal cavity, and you can slowly absorb it then. Okay, so just shunt. You can have tumors. So if you have a tumor and it compresses against your ventricles and kind of causes stenosis. You can have infections where you scar this area and cause scar tissue to form, and that causes an obstruction. So any different ways you cut it, you can have some sort of obstruction, causing them to no longer communicate with each other. We call that non-communicating hydrocephalus. Now, just when you thought you had the grasp of it, I'm going to throw you a curveball. There are two disorders that don't really fall in this trend. The first disorder is called normal pressure hydrocephalus. What the heck? Normal pressure hydrocephalus? Isn't that like a contradiction? How do you have hydrocephalus and it's also on normal pressure. This is because it's very slow and insidious and sometimes episodic. So you have kind of time to equalize itself out. So I'll just write insidious. But you do have hydrocephalus. You do have that increased fluid, and it will eventually warp your ventricular system, and it will warp your brain. Warping your brain, that just sounds so terrible, but that's what it does. It basically stretches fibers out, especially the fibers that are corona radiata. Corona radiata. And your corona radiata does a ton of things, but the culmination of all these signs, the slow insidious onset and just brain warping, you're gonna have this slow loss of memory and executive function, dementia. As it starts to warp your ventricles and your corona radiata, it'll start to affect your movement, so you're gonna have gait instability or ataxia. But these two are somewhat really hard to say, oh, it's normal pressure hydrocephalus. However, the last one, which is always on question stems, is urinary incontinence. They will put an effort to say the patient has urinary incontinence. Every single question that I ever got on normal pressure hydrocephalus had urinary incontinence kind of labeled out there. So if you have that in the back of your mind, it's easy to pick up. So that's the first disorder that's kind of wonky. The second disorder is going to be something called idiopathic cerebral hypertension. This is basically raised ICP that we don't know the cause of. That's the idiopathic part of it. However, it seems to be very commonly seen in young, obese females. So in a young, obese female who's otherwise healthy, complaining of headaches, you see papilla edema, you're thinking of this. Some theories of why it affects young, obese females, it might have something to do with hormone changes. So especially if a patient is taking OCP, it seems to be an increased risk. So I'm not going to write that down because it's just a theory and they're not going to test you on it. But another risk factor that you should know is if they use vitamin A for whatever reason. Vitamin A can be used for cystic acne. So if some young obese female comes in that has cystic acne and has papilledema, headache, you're thinking of raised ICP. One of the treatments you can do is weight loss, which seems to regulate hormones and kind of reduces the fluid. Acetazolamide. That's a drug in our renal block. Didn't think you'd see that again. What does acetazolamide do? That's a carbonic anhydrase inhibitor, which seems to reduce CSF. I don't know if your epidermal cells use that carbonic anhydrase to make CSF, but this is a common drug we give, acetazolamide, so you gotta know that. And if it gets really bad, we can do procedures where we basically suck out some CSF. We can do lumbar puncture, where you go into the spine and you basically suck out CSF from the subarachnoid space. And one of the classic signs is when you put that lumbar puncture and you have this giant opening pressure, just blow back from all that CSF. So if you see increased opening pressure, that is another big sign. Kind of like sticking a needle into a tire. Yeah, you just stick it in and all that pressure just blows back. So opening pressure sign. That's hydrocephalus and all the causes of raised CSF. But there's one more thing I want to talk about. And it's actually not hydrocephalus. So why am I talking about it here? It's something that looks like hydrocephalus. See the running theme in neuroanatomy is if something's missing, then something else will take its place. It will enlarge and take its place. And your ventricular system is no different. So if you have brain atrophy, and you reduce the mass of your brain, then your ventricles will take its place. Your ventricles will enlarge, ventriculomegaly. And you'll see those enlarged ventricles on imaging, but the ICP, the pressure, the amount of CSF will be normal. Right, ICP normal. Because it's not really a problem with your ventricles or your ICP, it's basically a problem with your brain. And your ventricles are just kind of taking its place, okay? So it looks like hydrocephalus, but it isn't. What can cause this brain atrophy? Well, Alzheimer's is a big one. All right, so a patient comes in, has all the classic signs of Alzheimer's, and then they might ask you, what do you see on imaging? Ventriculomegaly, brain atrophy. We call all this ex vacuo ventriculomegaly. Ex vacuo means vacuum, ventriculomegaly means enlarged ventricle. So because there's this vacuum of space because your brain's atrophied, then your ventricles will enlarge. Ex vacuo ventriculomegaly from brain atrophy. Hope that clears up your ventricular system. That's hydrocephalus. Hope you enjoyed the video. Thanks.